Hello, welcome to the Experts Are In, sponsored by BHL. I'm Dr. Chuck Browning with BHL. I'm the CEO and president, and here with my dear friend Joy Brunson-Nsubuga, who's the Chief Operating Officer at Recovery Innovations. Joy, we've been doing crisis together for 12 years.
Yeah, yeah. I can't believe it's been that long.
You time goes by really quickly. Thank you so much for being here with me so that we can talk about an important subject, and that's substance use disorder in crisis. And I'm going to start out by telling this story. I know you've heard it because we've done this presentation before at some different conferences. But basically, this picture is a representation of me back in my toddler years, probably early 70s. I was probably 2, 3 years old, standing up in the middle of the car, facing forward as we were going to a family member's house for Christmas Eve celebration. And we were going down the highway in the nighttime and hit a car. And I mean, hit a, not a car, we hit a cow. And as we were standing there, my parents threw their arms in front of me to keep me from going through the windshield. And basically, I'm lucky to be alive. Um, it was on one of those bench seats. And I mean, I should have, for all intents and purposes, gone through the windshield. However, thankfully, I didn't. And back then, in the 70s, there were seatbelts. I believe that probably the middle of that bench seat probably had a seatbelt. I do think there were seatbelts in the back seat as well, but not 100% sure. However, it wasn't necessarily that common, even though it was known back in the early 70s that seatbelts were a helpful tool. Joy, tell me a little bit about like your experience growing up in a different generation with your kids about seatbelts.
Yeah. As you're telling the story, I'm thinking, wow, that's really different because now I have to like double check any pictures that I put on social media of my children when they were in the back of the car or something like that. Because there is like you have to be on point with seatbelts, especially car seats, booster seats, all of that. It's taken on like a whole life of its own. And I remember the last time we did this presentation, I double checked the picture we used and made sure we had it. I had a good picture to show, and I still got an explanation from another mom who said that my son should not have been facing forward at that age. So it's just a whole nother world where seatbelts, car seats are just the norm.
And that's the whole reason that we told this story to intro this piece is that even in the 70s when we knew seatbelts were a helpful tool that could save lives, it wasn't a universal part of the system and the culture that we had. So there was different factors that made that the case. But nowadays, just like with Kanan and Izzy getting in their car seats, it's just like an automatic thing that we do. It's part of our legal situation. It's part of like click it or ticket. It's automatically built into our social fabric. Our cars have alarms and things like that that let us know if we're not buckled up. So I just think that it's a great example of what we're going to talk about today is that we actually do have some powerful tools for substance use. I always think about medications for substance use disorder that can be a helpful tool, peer support, harm reduction. Any other ones that you're thinking about, Joy?
I'm thinking of also just evidence-based treatments. How we have gone farther than just talk therapy, and we've moved into a lot more different and therapeutic tools that actually work and have shown to be more effective. So I think we've grown like completely across the board from where we started.
Totally agree. And this slide here is meant to help describe just one example of a tool that's very effective for substance use that's not used and not used wholeheartedly because of system challenges. And so this whole slide, just to put it into layman's terms, it reflects different treatments and something called numbers needed to treat. And so that just means that if you did a particular treatment for someone, um, for example, right here where it says antihypertensives or stroke, and it's a number needed to treat of 125, Joy, that just means it would take 125 people to be treated by blood pressure medicine to prevent one stroke. So you have to use that many people to help see the effect of one benefit. And obviously, you can see Up at the top, we've got two examples of treatments, medications for opioid use disorder, buprenorphine and methadone. For buprenorphine, it only takes 3 people to treat to prevent one overdose. For methadone to keep people in care, it only takes 4 people to treat for one person to stay in care and be engaged in care. So if you think about it, Joy, like, I mean, think about the numbers of that. We spend billions of dollars in healthcare with medications that have way worse effectiveness. And yet, I'm sure you know this, what the stats on like how many people get access to MOUD that have abuse use disorder.
Yeah, the percentages are shockingly low. And even lower in rural areas. It's down to like 10% in certain rural areas. But as a therapist, Dr. Shuck, thank you for explaining this to me because this slide didn't mean as much until you explained it. But also, I think when you're looking at the 3 individuals or 4 individuals, it also shows the point of the medication, like what are we trying to do, and I think sometimes that also gets lost in substance use treatment, preventing overdose, keeping individuals in care, giving them a chance to be able to heal physically and emotionally and all of that, and make different decisions. I think it's important to think about that point because oftentimes, um, as family members and friends and caregivers, sometimes we think about MOUD or medications as more of a way to kind of I'm trying to think of the word like cure the the substance use, like cure the diagnosis, and that's not necessarily what it's for. These challenges are lifelong, and so being able to see what the medication is for, I think, is also helpful. In addition to um, how many individuals it actually takes to treat in order to be for the medication to be effective.
Totally agree, Joy. And that just goes again that stigma is one of the factors that impacts access. And if you think about it, when we have high blood pressure or high cholesterol, there is no focus necessarily on a cure. We work with people on managing a long term illness. And that's the way most substance use disorders are for people that are having significant challenges with it, is that it's a chronic illness, and being able to look at it like that, like how can you manage it and live a life of recovery even though you're dealing with it. So that's a super great point. As we move forward then and talking about these systems that we have that are challenged, so we have things that could help people do better in their challenges with different substance use problems. I have, and you and I have talked about this a lot, but tell me a little bit about how you feel how crisis system could impact overall system improvement for care for substance use.
Well, I think it's all about access. So when we think about the crisis continuum, and you think about being able to call 988 now, which has been a game changer in allowing access for individuals to be able to call and have someone on the other end who is well versed in what their challenges are and being able to support them. Having someone who can respond to you, come out to where you are, and also having a place to go when it's deemed necessary that is specially designed to suit exactly what challenges you're having. Like, that is a game changer. We take for granted, I think, or maybe I do because I was born in the 80s, take for granted the medical equivalent of that, being able to call 911. Like, that system was already established by the time I arrived on the planet. But showing others that there's also a system that is designed to treat behavioral health crises, and specifically substance use crises. The access that we have now is so much more effective. It doesn't necessarily mean like you have to live in a certain place or you have to be in a certain county, because sometimes, care can be very county specific. Like it's really opening up access to everyone. And I think that is critical when it comes to being able to ask for help when you are experiencing a substance use crisis.
Totally agree, Joy. And we're going to go to some slides to kind of illustrate for people who haven't been aware of the development of this system to help maybe illustrate it even better and make sense. Um, Pre 988, people, if they were in challenges with a crisis, whether it's mental health or substance use, they would normally either go to an emergency department or reach out to 911. And so what happens when you call 911? Who's coming?
The police are coming, EMS might be coming, fire
Uh,
might be coming. Like you don't really get a choice. It all depends on what you say. It could be all three.
It could be all three. And then if you need a higher level of care and you can't be managed where you are in the community, the gatekeeper back pre 988 was to go to crisis hospital, go to an emergency department, excuse me. And that's where a lot of, flow management, valve problems happen. People end up in long waiting times. And especially you and I, who've worked with a lot of people with substance use over time, we also know that sometimes the trauma and the experience that they get from repeatedly going to an emergency department and feeling like they're not wanted or a trouble to the emergency department as well.
Yeah. I'm thinking of specific stories of individuals who it's just hard when they're asking for help and they're not getting the help that they need. But also when you hear from physicians or nurses that work in the emergency departments, they're there to save lives from car accidents and all of those things, and they didn't necessarily go into the field to treat substance use disorder. So there is a clash that happens when individuals go to the ED.
And so the innovation in that system, we often credit some of the things related to the Crisis Now movement, which is a big foundation of the main pillars of 988's someone to contact someone to respond in a safe place for help in the Phoenix model. So in this next slide, you can see in that Phoenix, Arizona area, we started developing things like mobile crisis teams that could go out in the community similar to EMS and specific crisis facilities where law enforcement or first responders could drop someone off and be in and out in 5 minutes or less and have that person connected to two types of services that are equivalent to emergency physical health care services that are designed specifically for them. And then talk about the impact that that's had in Arizona, Joy.
So the impact that has had in Arizona, specifically that model, we've seen not only a savings across the board for emergency departments and just the whole system in general, but we've also seen that when police officers or any first responder is able to go to a crisis facility to bring someone, or they may not have to go out at all because a mobile crisis responder has been sent. We're also seeing a decrease in the number of FTEs that are needed, the number of hours that are spent doing things that are outside of their job and away from public service. And then we also see, which I think is the biggest one, and I know Dr. Chuck, you agree as well, that care fit to need is something that you say often. That quality of care, being able to have services that are specifically designed for someone when they are in a behavioral health crisis is just gold. Like
It
that
is
is
gold.
the best
Agreed.
possible outcome that you can have.
And that we forward to the last slide, which is post 988. So now we look at when you implement 988, you have a complete way that unless it's an emergency for mental health, for medical problems or an emergency for law enforcement in terms of imminent danger to public safety, we can bypass EDs and law enforcement completely through the new pathway that's going on. And so could you talk a little bit, Joy, about how you see this being able to make an impact if executed correctly for substance use?
You're right. poking on my hopes and dreams and wishes since I since I came into this field. Um, the impact that this system can have in any community, if it is done correctly, is again we are saving the emergency departments for what they're needed for. Those acute situations, those physical health emergencies, and then also for the first responders, we are keeping them within their scope of practice. And then also being able to ensure that they are addressing any public safety threat or issue or challenge that's what they're focused on. Think about all of the traumatic events that we would be saving for an individual who has simply just reached out for help. And then also because substance use has the stigma, Dr. Chuck, that you talked about earlier, um, having a system that understands exactly what is going on for an individual, whether it's being able to tell the substance, the level of intoxication, being able to get someone safely into care when needed, being able to use motivational interviewing techniques that continue to engage someone if they're calling over and over, or for a mobile crisis team to go out to them and continue to engage them and support their families while getting them into care. Think about the change that would make for not only the individual that is experiencing the challenge, but also for their family members. And we know, Dr. Shock, in the substance use field, that it's not like a one and done type of situation. Oftentimes, we have to continuously engage individuals into care. And to be able to do that in a welcoming environment, being able to do that with individuals who know that it could be the fifth time, it could be the 15th time.
Yes.
But being able to have that care and compassionate voice over and over until someone is able to make a different decision about their recovery, I think would be a game changer.
It is Joy. And I think, the hope of this is that going back to what we talked about, that there are tools out there that work and so many people just don't have access to them. Anyone that's in crisis, if we have this executed across the country and those services along the crisis continuum have the infrastructure ready to be able to help support people with substance use and connect with them and engage with them, and that it's open to everyone, that's the game changer, is being able to do that. And what we're going to talk about is like that's why we 98 is universal now, and it is pushing us forward, and that's great. We've still got ways to go to fill out the continuum in every place in the United States, and we also have ways to go in just the care practice and what we do, especially in building in substance use and not just mental health supports into the crisis spectrum. So this next slide reflects on some of the essential crisis care system principles that were outlined in some of the national guidelines. And you can see focus on things like recovery needs, trauma informed care, safety and security for both the staff and the people you're serving, zero suicide or safer care models, a significant use of peers, and then that coordination through first responder. All those things that were talked about in the crisis are so layered and connected to the substance use world. And even in our crisis spectrum where we're supposed to specialize in that, there are still gaps and a lot of areas where we can improve in being able to have that overall infrastructure to support the specifics of substance use in a call center, in somewhere to respond, in a safe place for help. Any thoughts on that, Joy?
Well,
We
I
have
was just
our own journeys of challenges to execute that. It's still working on it.
still working on it, still working on it, and I hope we never get to a place where we feel like we're there because we will be not challenging ourselves to continue to move to a better place as we're providing care for individuals in need. But I will say the significant role of peers is so important. Individuals who have been there, who are a living embodiment of recovery, but also know what it feels like to ask for help and being able to have individuals with lived experience there to engage continuously throughout any part of the crisis continuum, I think is one of the big important factors. And then also that safety and security for all. Um, Being able to have a system that includes substance use challenges and being able to care and treat that um, gets us closer to a system that is able to support everyone who asks for help. That's not something that we have historically had. It is something that especially here in the U.S., individuals of color have been very wary, and rightly so, of systems that are in place. And so being able to continue to push forward the care that we have, making sure it really is not excluding individuals. We're not putting up barriers for individuals to access the care, and it's safe for everyone. I think those are the two that are important for me. What about for you?
No, that was a big one, Joy. We talked about earlier in the session that so many times folks with substance use have bad encounters with different systems as they're trying to get help, or even beginning to even think about getting help. And so having that trauma informed lens that says we want to create a place that's engaging and welcoming to help you work on your recovery needs is super important. And that's for everyone, like you said. The other piece is to make that workflow that we talked about with the 988 and crisis system model work for substance use. Every person that can't get connected to supports to be able to stay in the community by 988 for substance use is another person that needs a higher level of care that might not have. And every time a mobile team can't go out and see someone because something's going on with substance use and they don't have the infrastructure to manage it, is another time that law enforcement's going to have to go instead, probably. And then every time that we send somebody out for medical clearance, unless at a safe place for help, that maybe we could have helped support them. Again, that's another reason. And you and I have seen it a bunch of times at a crisis facility where when someone goes to an emergency department, their mind may change then and they may not come back to get help when they actually were willing to just a few hours earlier. So that opportunity and the ability to connect when the iron is hot is so important. And that's part of that safety security for all and those kinds of things to me.
Yeah, it needs a sub bullet of like training and support for staff to be able to manage
Ah,
all of these
you segued
different
into my
types.
next slide,
Oh, did
Joy. Yeah.
I?
So
Oh.
this is work that you and I did actually for RI to think about our overall systems and what we wanted our staff to be able to make sure that they could take home. And if for us to support SUD, and we were talking about the safe place for help lane, but it's applicable to all aspects of the crisis continuum in the focus of substance use, and that's having recovery focus and trauma informed care. But it's a special unique thing for substance use is that there's going to be both physical and mental health needs in addition to supporting substance use disorder. And if you, any of those things that you can't do means a person is not going to be able to be supported in that continuum we described. And then the other big piece is you have to be able to have your staff have some training and understanding and ability and tools to be able to deal with intoxication and withdrawal. So, we focused in the work that we've done together in training, the staffing models that we have at BHL. We've really been focused on improving the technology tools. And so, as we get into a later piece of this webinar, because it's going to be a multi-part series, we'll talk in some specifics of technology and quality systems that organizations, regions, cities, and states can use to do that continuous quality improvement to make sure we're caring for people the way we want to. What's your take home on training things in our work together, Joy? Any specific nuggets or pearls of wisdom you'd suggest overall?
Lots of wisdom. I would say um, the things that we've discovered is that our team members want to help. They want to be able to care for individuals, and it's the lack of confidence or protocols and the training that we've seen that staff are hesitant in what we say saying yes to someone, and that could mean going out to someone, that could mean inviting someone into a crisis facility. The more tools and resources and training that's provided, and that's very detailed on every type of situation that they may encounter, we see confidence continue to increase, and individuals being able to say yes, because they are the ones that are going out, they are the ones that are at the door welcoming individuals. So that's what I think I've learned from our experience with um, adding in and continuing to add in more robust infrastructure for substance use care is kind of getting into the details and providing that training in order to support the confidence of the team members.
100%. And as we go into our next webinar, part two, if you're going to be willing enough to do part two with me, Joy, we're going to go and take a deeper dive at each level of the crisis continuum and get into some of the specific things about training, staffing, technology, things that make a difference, and quality systems that go along with that. So as we close for this first session, I just, going back to the story about our seatbelts, now it's so normal, just like it was for you to put Keenan and Izzy. It wasn't even a question about that of having them standing up in the middle of your car while you're going down the road. But it took policy, it took culture, it took work. We had to overcome stigma to be able to break those systems down and make it so that it's so automatic now. And I hope the take home from this session is that we do have some amazing tools that could work. And we have this system in the crisis system that creates an unbelievable opportunity to make that come together and create that kind of just natural ability that if you have these challenges and you enter in the crisis system, you're going to get good care, and it's going to be just as natural to have it happen compared to where our system is now, where there's lots of gaps and lots of challenges in making that happen. So thank you for your time and spending time with me today. I enjoyed talking about this, and I'll look forward to part two where we get into some more granular detail.